Welcome to the deep dive. Today, we're plunging into the hidden power of a small but mighty gland, your thyroid. It's that butterfly-shaped organ you probably don't think much about, yet it silently regulates almost every system in your body, your heart rate, your metabolism. But what happens when this master regulator goes, well, completely off the rails? That's our mission today. We're taking a deep dive into hyperthyroidism. It's a condition where this tiny powerhouse produces way too much hormone. It essentially puts all your body's systems into a constant high-speed chase. Imagine your body as a car, and the accelerator is just stuck to the floor.
Right. And our goal today is really to give you a clear, comprehensive understanding of this complex condition.
Right.
We'll unpack the surprising ways hyperthyroidism can show up, how doctors use, clever lab work to pinpoint the diagnosis, and the tailored treatment options available. You should walk away, hopefully, well-informed, ready to understand the nuances of this revved-up thyroid.
All right, so if our body is this car with the accelerator stuck, what exactly does that mean biologically speaking? Like, at its core, what is hyperthyroidism?
Simply put, hyperthyroidism means you have elevated levels of free thyroid hormones, specifically T4 and T3. And this leads to what we call a hypermetabolic state. Your body is just running too fast. But the key insight here, I think, is that you can have what looks like the same condition on paper, but your body reacts to it very differently. We differentiate between overt hyperthyroidism, where both symptoms and lab tests scream overdrive, if you will,
Okay.
and subclinical, where the body's chemistry is off, sure, but symptoms might be whispers or even silent.
Whispers.
And this distinction is crucial because it really changes how we approach it.
So it's not always as obvious as we might think. And how common is this condition? Is it rare?
It's actually more prevalent than you might expect. It affects about 0.2 to 1.4% of the global population.
Yep.
And here in the U.S., it's around 1.3% overall.
Okay.
It's significantly more common in women, about a 5-to-1 ratio, we think.
Wow, 5-to-1.
Yeah, and it's also more frequent in smokers. What's truly notable, though, is that this prevalence increases to 4 or 5% in older women.
That's a pretty significant increase. It really underscores how pervasive this can be, especially later in life. So, when someone's body is stuck in that high-speed chase, what does that actually feel like day to day? What are the classic symptoms of this constant overdrive?
Well, the classic symptoms of overt hyperthyroidism are quite dramatic, typically. Patients often experience anxiety, emotional falivity.
Meaning quick mood swings?
Exactly. Quick, intense mood swings, and just a pervasive nervousness. Physical signs include palpitations, a fast heart rate tachycardia, and tremors. They're also frequently intolerant to heat and perspire more.
Right, sweating a lot.
And a surprising detail for many is weight loss, despite a normal or even increased appetite.
That's the one that always gets me. Weight loss, but eating more.
It sounds counterintuitive, doesn't it? And sometimes, for younger patients, it actually swings the other way. That excessive appetite can lead to weight gain in some cases.
Huh.
Other common complaints include an increased frequency of bowel movements, basically. Your digestive system speeds up too. We call it hyperdefecation, though it's not always full-blown diarrhea.
Got it.
And then there's generalized weakness, fatigue, insomnia, and sometimes shortness of breath, just feeling worn out but wired.
That sounds like an enormous burden to live with, just exhausting. But you mentioned earlier that sometimes the symptoms can be much milder or even isolated. What specific sort of isolated symptoms should really raise a flag for someone or their doctor?
Right. This is where the aha moment often happens, for doctors and patients. While we think of those classic dramatic symptoms, the real insight, I think, is that hyperthyroidism can whisper, not shout. Isolated clues like unexplained weight loss or maybe a new irregular heartbeat, especially in older adults, those are just minor annoyances.
They're red flags.
They're critical red flags that really demand a thyroid check. It's often these subtle signs that reveal that hidden accelerator-stuck issue.
Okay. What else?
Other isolated symptoms could be muscle weakness, what we call myopathy. In women, menstrual disorders, irregular or absent periods can be a clue. And in men, things like gynecomastia, breast enlargement, or erectile dysfunction.
Really?
Yes. And they can also worsen conditions like osteoporosis or heart failure, or make existing diabetes harder to control.
It sounds like a paradox, doesn't it? You mentioned this apathetic thyrotoxicosis, hyperactive but apathetic. This seems really critical, particularly with older patients, where you said hyperthyroidism can be incredibly stealthy. How does that manifest differently?
It truly is a paradox.
Yeah.
In older patients, the presentation can be very, very atypical. Instead of those classic high-energy symptoms, you often see cardiopulmonary issues dominating.
Like heart and lung problems.
Exactly. Things like a persistent rapid heart rate or atrial fibrillation, that irregular heartbeat again, shortness of breath with exertion, ankle swelling, edema. They also tend to experience more significant weight loss, but often without the increased appetite we see in younger folks. And what's crucial here is that they may even present with symptoms that look a lot like depression or dementia, often without the more typical physical signs like, bulging eyes or tremor that we associate with classic hyperthyroidism.
Wow.
Yeah. So it really underscores why careful clinical suspicion is so important in this age group and to think about it.
Definitely. Okay, so moving from those subjective symptoms we've just discussed, what might a doctor actually see or feel during a physical examination? What are the objective signs hinting at this overdrive?
A physical exam can reveal several telling signs.
Sure.
Generally, patients with overt hyperthyroidism might display, hyperactivity, maybe rapid speech. Their skin is typically warm and moist. Their hair can be thin and fine. Brittle nails, too. Sometimes they separate from the nail bed. That's called onycholysis.
Onycholysis. Yeah.
Cardiovascularly, you'd often find that fast heart rate, tachycardia.
Mm.
Also, a wide difference between the systolic and diastolic blood pressure readings, a widened pulse pressure, and a noticeably forceful heartbeat, what we call a hyperdynamic precordium.
You can almost feel the heart working over time.
You can. Neurologically, tremors are common. Weakness in the muscles closest to the body, proximal muscles, and exaggerated reflexes. And in the eyes, you might see that constant stare because the eyelids are pulled back, retracted, and something called lid lag.
Lid lag.
Yeah, where the upper eyelid takes a moment to follow the eyeball when the person looks down. These subtle eye signs are direct results of the body being in sympathetic overdrive.
Got it. And what about the thyroid gland itself? Will it always be visibly enlarged like a goiter, or could there be other changes, or maybe no changes at all?
That's a good question because the appearance of the thyroid can really vary. A goiter or nodules may be present. It depends on the cause. So, for example, in Graves' disease, or what's called toxic multinodular goiter, the enlargement can range from minimal to, quite massive. But it's important to remember the thyroid might not be easily felt, might not be palpable in some older patients, even if they have Graves' disease.
Okay, so size isn't always the indicator.
Not always. In other cases, like painless thyroiditis, there might be no enlargement or minimal or maybe just modest enlargement. Conversely, if there's no thyroid enlargement at all, that might suggest the hormones are coming from outside the body, exogenous hormones, or even a rare condition where functioning thyroid tissue is in an ovarian tumor, struma ovariae.
In an ovary?
Wow. Yeah. If a doctor feels just a single lump, a single nodule, that could be an autonomously functioning adenoma. And if the thyroid is actually painful and tender to touch, that often points towards an inflammatory condition called subacute thyroiditis.
Okay, that makes sense. Now, beyond these general signs, you mentioned specific visual clues that point directly to Graves' disease. These are unique, right? Only with Graves?
They absolutely are. Two key manifestations are pretty much exclusive to Graves' disease. First, there's thyroid eye disease, also known as orbitopathy or Graves' ophthalmopathy. This isn't just about those eye signs like lid lag we mentioned. It's actual inflammation of the fat and muscles behind the eyes.
Inflammation behind the eye.
Yes. And this leads to symptoms like proptosis, bulging eyes, swelling around the eyes, sometimes double vision, limitation of eye movement, even orbital pain.
That sounds serious.
It can be. And smoking, older age, and being male are key risk factors for developing or worsening it.
Okay. And the second unique sign?
The second one is infiltrative dermopathy, often called pretibial myxedema. Now, the name is a bit confusing because myxedema usually makes us think of hypothyroidism, low thyroid.
Right.
But here in Graves, it's this non-pitting, kind of raised, often itchy infiltration of the skin, typically on the shins. It can look a bit like an orange peel texture, sometimes hyperpigmented.
Orange peel skin on shins. Strange.
It is. And it's crucial to remember that this rarely occurs without the eye involvement of Graves' disease as well. Usually they go together if the skin condition is present.
Got it. So, unique signs for Graves. Okay, so once someone presents with these symptoms or physical clues, the next crucial step is lab tests. This is where doctors really read the dashboard of the body, right? How do clinicians confirm hyperthyroidism and start to figure out the actual cause?
Absolutely. The initial diagnostic approach relies heavily on lab tests. The best first test is a serum TSH thyroid stimulating hormone. If that TSH level is low, then typically additional tests for free T4 and free T3 are automatically measured by the lab, or the doctor orders them.
And why is TSH the key starting point?
Well, it's key because nearly all primary hyperthyroidism cases, meaning the problem is in the thyroid gland itself, will show a low TSH, often really low, like below 0.05 MUL in overt cases. It's the body's feedback loop. The pituitary gland sees all this T4 and T3 floating around and says, whoa, too much, and stops sending the TSH signal to the thyroid.
Yeah, it's trying to put the brakes on.
Exactly.
But it sounds like there's more to it than just a low TSH light flashing. What are the specific patterns of these thyroid function tests? How do they tell us what's really going on under the hood?
Right. It's not always as simple as just low TSH, high T4 and T3. There are patterns. Sometimes we see what we call T3 toxicosis, where only the T3 level is high, T4 is normal, but TSH is low. This often happens early in the course of Graves' or nodular disease.
This T3 is high.
Or you might see T4 toxicosis high, free T4, normal T3, low TSH. This can happen if someone has another concurrent illness that affects T4 to T3 conversion, or maybe with certain medications like amiodarone. So the key takeaway is that doctors look the entire picture, TSH, free T4, and T3, not just one number. That helps distinguish overt hyperthyroidism, low TSH, high T4 and or T3, from subclinical hyperthyroidism, low TSH, but normal T4 and T3, which is often picked up through routine screening tests.
Subclinical, right, the whispering kind.
And there's a very rare exception to the low TSH rule, TSH-mediated hyperthyroidism. That's usually due to a pituitary adenoma, a tumor making TSH, so TSH is normal or even high, despite high thyroid hormones. But that's really uncommon.
Okay, that's a fascinating range of results. But in the real world, things are rarely so clear-cut, are they? What are some of the trickiest conditions or factors that can mimic hyperthyroidism and potentially lead to a misdiagnosis?
You're absolutely right. It's not always straightforward. And probably the most crucial mimic to be aware of today, especially with the rise in supplement use, is assay interference from biotin.
Biotin, like in hair and nail supplements.
Exactly. If someone is taking high doses, typically 5 milligrams or more, it can mess with the lab tests. It can cause falsely low TSH readings and falsely high T4 and T3 levels. Looks just like hyperthyroidism on paper.
Wow, so someone could be told they have hyperthyroidism when they don't.
Potentially, yes. It's critical to ask about biotin use, and if they are taking it, to stop it for at least 2 days, ideally longer, and then repeat the thyroid tests.
Good to know. What else can look like hyperthyroidism but isn't?
Well, TSH can also appear low without actual hyperthyroidism in other situations. Things like central hypothyroidism, where the pituitary isn't working right, or during recovery from being actually hyperthyroid, the TSH can stay suppressed for weeks or months even after T4 and T3 normalize. Also, severe non-thyroidal illness, sometimes called sick euthyroid syndrome, especially if someone's on glucocorticoids or dopamine.
Okay.
And TSH levels can be physiologically lower in early pregnancy, or sometimes just naturally lower in some healthy older individuals or some healthy Black individuals. So the key insight here, we always need to confirm a persistently low TSH, usually by rechecking in 1 to 3 months before diagnosing, say, subclinical hyperthyroidism, because these transient dips can occur.
Right. Don't jump to conclusions based on one test. Okay, so once hyperthyroidism is confirmed and you've ruled out mimics, the next crucial step is figuring out the cause. You said treatment depends entirely on this. How do clinicians figure out why the thyroid has gone rogue?
Absolutely. Identifying the cause is paramount, because the treatment strategy flows directly from that. From a fundamental viewpoint, hyperthyroidism results from one of 2 basic mechanisms. The first is increased thyroid hormone synthesis. Basically, the thyroid gland itself is actively overproducing hormones. It's working too hard.
The factor's running overtime.
Exactly. And we identify this mechanism using tests like a radioiodine uptake scan, which would show high uptake of iodine, or sometimes a thyroid ultrasound showing high blood flow. The thyroid is hungry for iodine to make more hormone.
Okay, so high uptake means it's making too much. What's the second mechanism?
The second mechanism involves the release of preformed thyroid hormone, or hormone from exogenous or ectopic sources. Here, the thyroid isn't actively making significant amounts of new hormone. It's either leaking stored hormone because the gland is damaged or inflamed.
Like a leaky container?
Sort of, yes. Or the hormone is coming from entirely outside the thyroid, maybe medication, or that rare ovarian tumor we mentioned. And this mechanism is identified by a low or nearly absent radioiodine uptake or low blood flow on ultrasound. The thyroid isn't actively taking up iodine because it's not in production mode.
Got it. Making too much versus leaking or coming from elsewhere. That's a really clear distinction.
It's the crucial first branch point in figuring out the why.
Okay, let's start with the overproducers, the causes where the thyroid is actively synthesizing too much hormone. What falls into that category?
The most common cause by far in this category is Graves' disease. It's an autoimmune disorder. Basically, the body makes antibodies that mistakenly stimulate the TSH receptor on the thyroid cells. It tells the thyroid to work overtime, make lots of hormone, and often grow bigger.
So the body's own immune system is pressing the accelerator.
Precisely. And it can sometimes be triggered by things like stressful life events, high iodine intake, certain medications. There have even been some rare reports after things like viral infections or vaccines, though big studies haven't confirmed a widespread link there.
Okay, Graves is number one. What else causes overproduction?
We also see toxic adenoma, that's a single nodule gone rogue, and toxic multinodular goiter, where multiple nodules are overproducing hormone. These are caused by overgrowth of thyroid cells that operate independently of TSH regulation, often due to specific genetic mutations in those cells. These become more common as people get older, especially women, and particularly in regions where iodine deficiency used to be common.
Right, the nodules just do their own thing.
Exactly. Less commonly, you can get iodine-induced hyperthyroidism after a large iodine load, like from CT contrast dye or the heart medication amiodarone. Though, confusingly, the radioiodine uptake test might be low initially if there's still a lot of iodine around. And then there are very rare causes like certain pregnancy-related issues, trophoblastic disease, or those TSH-producing pituitary adenomas we touched on earlier.
Okay. Now, let's switch gears to the second mechanism, where the thyroid isn't actively overproducing, it's leaking stored hormone, or the hormone is coming from somewhere else. What are the main causes here?
In this category, thyroiditis, meaning inflammation of the thyroid, is a major player. This involves inflammation and often destruction of thyroid tissue, which causes the release, the lackage of preformed hormone that was stored in the gland.
So it's like dumping the reserves.
Exactly. And it's usually transient. It happens, then it often resolves, sometimes followed by a period of low thyroid function before recovery. Critically, antithyroid drugs don't work here because the thyroid isn't making new hormone. It's just leaking old stuff.
Right, you can't stop production if there's no production happening.
Precisely. Examples include subacute granulomatous thyroiditis, which is often painful and thought to be viral, or painless thyroiditis, sometimes called silent or lymphocytic thyroiditis, which is part of the autoimmune spectrum and can happen postpartum. And some drugs can induce thyroiditis too, like amiodarone again, or newer cancer therapies called checkpoint inhibitors.
Okay, thyroiditis. What else falls under this low uptake category?
Then there's exogenous hyperthyroidism. That means the thyroid hormone is coming from outside the body. The most common scenario here is factitious ingestion, someone taking too much thyroid hormone medication, either intentionally or accidentally.
Taking thyroid pills they don't need or too high a dose.
Yes. And finally, there's ectopic hyperthyroidism. This is rare, but it involves functioning thyroid tissue located outside the neck. The main example is struma ovarii, where thyroid tissue is part of an ovarian tumor and producing hormone. A radioiodine scan would actually show uptake down in the pelvis.
Wow, that's wild.
It is. And very, very rarely, large metastases from follicular thyroid cancer can produce hormone.
Okay, so we've confirmed the diagnosis, we've figured out the cause, whether it's overproduction or release external sources. Now it's time for treatment. What's the core principle here?
The core principle is really twofold. First, rapid symptom control. Get the patient feeling better quickly. And second, addressing the underlying issue, either stopping the overproduction of hormone or managing the source if it's external or due to release. We want to get the body out of that high-speed chase mode and then tackle the root cause.
Makes sense. And how do you achieve that rapid symptom control you mentioned?
We typically start with beta blockers, medications like atenolol or propranolol. These are often started very early, sometimes even before the definitive cause is known, because they're fantastic at ameliorating and calming down those symptoms caused by the body being in sympathetic overdrive.
Like the racing heart, the tremors.
Exactly. Palpitations, rapid heart rate, tremulousness, anxiety, even heat intolerance can improve quite quickly with beta blockers. But what's crucial to understand is that while they significantly improve how the patient feels, they don't treat the root cause of the hyperthyroidism itself. They simply buy us time and provide relief while we figure out and start the definitive treatment.
Right, they manage the symptoms, not the source. Okay, so once symptoms are somewhat under control with beta blockers, what are the main treatment options aimed at actually decreasing the thyroid hormone synthesis for those cases where the thyroid is overproducing? I understand there are three main paths.
That's right. For causes involving overproduction, like Graves' disease or toxic nodules, there are three main treatment modalities. They are antithyroid drugs, radioiodine ablation, and surgery. And you're right, they are all effective, but each comes with its own distinct set of considerations, pros and cons.
Let's break them down. What about antithyroid drugs first, sometimes called thionides?
Okay, so antithyroid drugs, or thiamides, the main ones are methimazole and propylthiouracil, or PTU. They work by blocking the enzyme steps involved in making thyroid hormone. They inhibit synthesis. The upside: there's a chance of achieving long-term remission, meaning the hyperthyroidism goes away even after stopping the drug, potentially avoiding permanent hypothyroidism.
A chance to get back to normal without lifelong treatment.
Potentially, yes.
Uh,
But they do come with possible side effects. Common ones include rash, hives, maybe some GI upset. More rarely, but seriously, they can cause a granulocytosis, a dangerous drop in white blood cells, or liver toxicity, particularly with PTU. So monitoring is required.
and how likely is that remission?
Well, remission rates vary. On average, maybe under 40% after a typical 1-2 year course. But some studies show higher rates, maybe over 80%, if treatment is continued for much longer, like 5-10 years, especially in milder cases.
Okay, so drugs offer a chance at remission but need monitoring and have potential side effects. What about radioiodine?
Radioiodine ablation uses a radioactive form of iodine, iodine-131. The patient swallows a capsule or liquid. Because the overactive thyroid cells are hungry for iodine, they absorb this radioactive iodine, which then destroys those cells over weeks to months.
So it targets the overactive tissue.
Exactly. The main advantage is it offers a permanent resolution of the hyperthyroidism. It's often the most common definitive treatment used in the U.S. It's less expensive and generally has a lower immediate complication rate than surgery.
Sounds effective. What's the downside?
The main disadvantage is that it almost always leads to permanent hypothyroidism. The thyroid is ablated, destroyed. So most patients, the vast majority, will need lifelong thyroid hormone replacement therapy afterwards.
Treating one condition for another in a way.
In a sense, yes, although hypothyroidism is generally considered easier to manage long term. There are also radiation safety precautions needed for a few days to weeks afterward, like avoiding close contact with young children or pregnant women. It can also sometimes worsen or rarely induce thyroid eye disease, especially in smokers. And it's absolutely contraindicated in pregnancy and breastfeeding.
Got it. Permanent hypothyroidism is the main trade-off. Okay, option 3, surgery.
Surgery, or thyroidectomy, involves surgically removing part, or more commonly these days, all of the thyroid gland. This offers a rapid and permanent cure for the hyperthyroidism. It's particularly beneficial for patients with very large goiters causing compression symptoms, or if there are suspicious nodules that need to be removed anyway. It's also generally the preferred option for patients with active, moderate to severe thyroid eye disease, as radioiodine can worsen it. And it's good for patients who can't tolerate the drugs or prefer to avoid radioiodine.
So, immediate permanent cure. What are the risks or downsides here?
Well, similar to radioiodine, it typically leads to permanent hypothyroidism if the entire gland is removed, total thyroidectomy, requiring lifelong hormone replacement. And it carries the inherent risks of surgery, potential damage to the nearby parathyroid glands, which control calcium, or to the recurrent laryngeal nerves, which control the voice box, plus general anesthesia risks. It's also generally the highest cost option up front.
Okay.
Patients usually need to take antithyroid drugs for a while beforehand to get their thyroid levels normal youth rate before heading into surgery to make the operation safer.
Right, stabilize things first. Wow, okay, 3 very different approaches. It sounds like a really complex decision-making process. How do you, or how does a patient and doctor actually choose? What factors influence that choice?
It absolutely is a complex decision, and it really should be a shared decision between the patient and their physician, incorporating several key factors. Patient preferences are paramount. How does the patient feel about the possibility of lifelong hypothyroidism? Do they have fears about radiation or drug side effects or surgery? What are their lifestyle considerations?
Makes sense. What else?
Disease severity plays a role. For mild hyperthyroidism, maybe trying antithyroid drugs for a chance at remission is a very reasonable first step. For more severe disease or in patients with high risks, like older age or heart disease, starting with drugs to stabilize and then moving towards a definitive therapy like radioiodine or surgery might be preferred. The presence and severity of thyroid eye disease is a major factor. As I mentioned, surgery is generally preferred over radioiodine if there's moderate to severe active eye disease.
Okay.
Also, large goiters causing symptoms or the presence of suspicious nodules often steers the decision towards surgery. And pregnancy planning is a big one. Ideally, definitive therapy with radioiodine or surgery should happen 6-12 months before a planned pregnancy to avoid needing antithyroid drugs during gestation. If that's not possible, PTU is generally preferred in the first trimester if drugs are necessary.
Lots to consider.
Absolutely. And one other thing, a really important post-treatment consideration, especially after radioiodine or surgery, is weight gain.
Ah, yes, you mentioned that. Why does that happen?
Well, hyperthyroidism revs up metabolism and energy expenditure. When you treat it, that expenditure goes down, often back to normal, or even lower if hypothyroidism develops. But appetite doesn't always decrease correspondingly, at least not right away. Studies show patients often gain significant weight, on average maybe 5.5 kilograms for women, 8 kilograms for men. So proactive dietary advice and managing expectations about weight is crucial.
That's a really practical point. Okay, let's circle back to something you mentioned right at the beginning. Subclinical hyperthyroidism. The low TSH, but normal T4 and T3. You said many patients have no obvious symptoms. So why is this still such a significant area of discussion? Why should we care about it if people feel fine?
That's a great question, and it's a really important area of clinical debate and research. While it might be subclinical in terms of obvious symptoms, this condition isn't necessarily benign. It carries potential long-term consequences that demand attention. First, there's always the risk of progression to overt hyperthyroidism, maybe 0.5 to 8% per year, depending on the TSH level and the cause. But perhaps more importantly, subclinical hyperthyroidism, especially when the TSH is very suppressed, say less than 0.1, is linked to significant cardiovascular effects.
Like what?
Increased risk of developing atrial fibrillation, particularly in older individuals. That risk can almost triple if the TSH is very low. It's also associated with increased heart rate, increased cardiac contractility, potentially changes in heart structure like increased left ventricular mass, and maybe even increased risk of heart failure and coronary heart disease events over time.
Wow, even without feeling palpitations necessarily.
Potentially, yes. The effects can be subtle but cumulative. It also impacts bone health. It's associated with reduced bone mineral density and an increased risk of fractures, especially in postmenopausal women.
So weaker bones.
Exactly. And if we look at the bigger picture, large population studies suggest there appears to be a small but increased risk of mortality associated with subclinical hyperthyroidism, particularly with more suppressed TSH levels. There's also some conflicting data about a possible increased risk for dementia.
Okay, so even if someone feels okay, there could be these underlying risks building up.
That's the concern, yes. And some people, even if they don't have classic symptoms, might find their quality of life is subtly impaired, maybe feeling a bit more anxious or tired than they realize, and treatment might improve that.
This leads to the crucial question then. When do we treat someone with subclinical hyperthyroidism, and when is simply observing them the right approach? It sounds like a balancing act.
It absolutely is a balancing act, and the approach really depends on several factors, including the patient's age, their overall health, the degree of TSH suppression, and the underlying cause. Now, if the subclinical hyperthyroidism is exogenous, meaning it's caused by taking too much thyroid hormone replacement, the answer is generally straightforward. Adjust the dose to bring the TSH back into the normal range, unless there's a specific medical reason for TSH suppression, like after treatment for thyroid cancer.
Okay, that makes sense. Adjust the pills.
Right. But for endogenous subclinical hyperthyroidism, where the body itself is the source, the decision is more nuanced. Guidelines generally recommend considering treatment for high-risk patients. That usually means people age 65 or older, or those with known cardiovascular disease, heart failure, or osteoporosis.
Okay, older or with pre-existing conditions.
Yes. For these individuals, if the TSH is persistently very low, less than 0.1 MUL, treatment of the underlying cause, like the toxic nodule or Graves', is generally recommended to mitigate those long-term risks. If their TSH is low but not quite that suppressed, say between 0.1 and 0.5, treatment is often suggested, especially if they have low bone density, underlying heart issues, or even subtle hyperthyroid symptoms. But careful observation is also a reasonable alternative in some cases, especially if their other risks are well managed.
And what about younger, lower-risk patients?
For lower-risk patients, say under 65, generally healthy premenopausal women, if the TSH is persistently very suppressed, less than 0.1, treatment might still be suggested, particularly if they're having symptoms, or if a scan shows an autonomous nodule likely to progress. but observation is often a reasonable alternative if they're truly asymptomatic. If their TSH is in that 0.1 to 0.5 range, observation is generally considered appropriate for most low-risk individuals.
So it really depends on the individual's risk profile and the degree of suppression.
Exactly. And remember, it's crucial to confirm that the low TSH is persistent by rechecking it after maybe 1 to 3 months before making any treatment decisions. You don't want to treat a transient dip.
Right.
The potential benefits of treatment in those who need it include improving some cardiovascular parameters, potentially improving bone mineral density over time, and sometimes enhancing quality of life.
So we've really covered a lot of ground here. We've journeyed through this broad spectrum of symptoms, from the obvious to the subtle, navigated the intricate lab diagnostics and the mimics, explored the diverse causes, and weighed the personalized treatment plans. It's really clear that hyperthyroidism is far more nuanced than it might appear just on the surface.
Indeed it is, and I think understanding these complexities, the different presentations, the diagnostic steps, the various causes dictating different treatments, truly empowers both patients and clinicians to navigate this condition much more effectively. It's really a testament to how finely tuned our bodies are, isn't it? And how much impact a single small gland like the thyroid can have on our entire system when it goes slightly awry.
It's truly incredible. The impact of this one small gland is just staggering. It really makes you wonder, doesn't it? If one small gland can so dramatically impact everything from your heart rate to your mood to your bone density, what other subtle imbalances might be shaping our health in ways we haven't yet fully grasped? What might a slight shift in any of your body's supposedly normal levels actually be signaling about a deeper story unfolding within us?